Good afternoon, everyone. Well, welcome to this afternoon session. Hear a lot of lively chatter over lunch, good Mexican food here in Austin. I am honored this afternoon to introduce the man that's actually responsible for my being here and for helping make this all happen. My boss, Dr. David Harmon, is a pediatrician who has been the chief medical director for Superior for, I believe, the last 8 years and has been with Superior for 10 years. He did his training with the military at the Uniformed Health Service in Bethesda and then with the Navy Medical Residency Program and spent some time serving overseas in Japan. And then ended up at the University of Florida, where he opened up one of the first clinics devoted to the foster care population. And with that, he gained some recognition because he was doing something that was considered very innovative at that time. And about 10 years ago, Texas awarded Superior HealthPlan the care of all of the foster children in Texas. And in order to help to run that, they tapped David Harmon to come here and help to get going the whole program at Superior, which turns out has become the model nationwide for foster care to be run by health plans and foster care in general. And David has emerged as the leading expert on foster care in the United States. He's also a leading expert on this whole concept of alternative payment models, being the largest Medicaid health plan in MCO in the state of Texas and as part of Centene, which is the largest Medicaid managed care organization in the country. We are really very keenly interested in moving away from fee-for-service and into these alternative payment models. And so he's going to take you on the journey of what is considered APMs, how can we envision this changing the way things are done in the healthcare system. And I think you'll appreciate some of the insight that he's gained over the years in looking into these. So without further ado, I'm going to introduce Dr. David Harmon. Thank you.
I don't know how to live up to that introduction, so I'm just going to level set real quick. As one of my bosses used to say, I'm just a simple pediatrician. So, and so I think of things simply, and I'm going to relay them in my simple way, but or try to. First, before I get started, I am going to do a little plug for Project Echo. Again, I know we've heard a lot about Project Echo. As Dan mentioned, I did train in the military. My first duty station after residency was in Yokosuka, Japan. And while Project Echo didn't exist at the time, I certainly utilized mentors back in the United States for cases that I encountered all the way over in Yokosuka, Japan. So in essence, the first kind of telementoring, if you will, much like the premise of Project Echo. And for a pediatrician fresh out of residency, it was vitally important. I was one of 3 pediatricians. One of the pediatricians was just a year ahead of me, had been in my residency program. So 2 of us fresh out of residency. And the third was a pediatric cardiologist who had been practicing pediatric cardiology for many years and for whatever reason decided to come back in, join the Navy as a general pediatrician, so hadn't practiced general pediatrics in many years. So the telementoring was invaluable to me at the time and helped me feel more confident about myself. And at the same time, we were fortunate enough in Japan to have both a child psychiatrist and a developmental pediatrician that I was able to get mentoring from on specific cases where I could take specific cases to them, present them to them, much the same concept of a Project Echo, and learn and manage them within my own practice. So while not exactly the same as Project Echo, I found it extremely valuable at the beginning of, especially at the beginning of my practice. But as I began to learn, and even as I set up my foster care program in Florida, went and visited a couple of other programs that had started up to learn from them and utilize them in a mentorship way as well. So just a big believer that this is something that's an important tool for us. So just wanted to throw that out there. After Corey's talk today, I was going to talk about alternative payment models and how we can fund what we've been talking about, but I think I've decided to just shift all our money and put it in the $31 billion deficit he referenced toward addressing social determinants of health. So I'm sorry if you were waiting for something else, but I'm done. No, just kidding. So I feel a lot of pressure, to be honest with you, because I can't tell you how many people are like, "Oh, this is the most important talk. How are we going to pay for all this?" And I just want to preface it by saying it's not going to end with some magic number saying, "Okay, this is what you're going to get for doing this," right? So this is going to hopefully lay some framework and begin the thought around a concept of how we might do this. So a few years ago, when CMS was starting to roll out some of their alternative payment models, they decided that there needed to be a group pulled together to really focus on this. And so the Department of Health and Human Services pulled together a public-private partnership called the Healthcare Payment Learning Activity Network. Is anyone familiar with that at all? Anyone heard about that? Great, good. Then this will be very pertinent to most everyone in the room. So as they came together, these public and private partners, they laid out these key principles for what they deemed to be alternative payment models. So their number one principle was that these models have to put patients at the center. They have to empower patients to be partners. They should play a role at some point in the development of these models, but also as part of these models, there should be a key component of some shared decision-making with patients that are part of these models. So that was their first principle. It should drive delivery system improvements, which is what we're talking about today. So you want to, the model as you set it up should begin to drive everyone in the same direction towards the same goal. It should shift to population-based payments, which is what most people think of when we talk about alternative payment models. One of the things we hear, and you'll hear a lot of different terms tossed out. I'm going to stick with the term alternative payment model today. But you may have heard value-based purchasing, value-based contracting, value-based this, and we'll hear people tell us, well, I'm providing you good value. You just need to pay me more for what I'm doing, right? And so it's about shifting to population-based payments, and certainly these incentives, as it says in number 4, should reach the providers that are providing the services, but the payments have to be tied to quality. They have to be tied to outcomes. So that was a key principle as well. They should be enough to motivate people to want to do the work, to do this population health work. And it should move to become the dominant form of payment ultimately. We should shift from, as Dan said, a fee-for-service model toward these alternative payment models. And that some of the things that are the words that are tossed around today, we need to create a common language, right? A common framework. So you hear things like PCMH, ACO, IPA, all these different terms, CPC plus now, MSSP, you name them. There's a whole bunch of terms thrown around today. We need to put them in a framework and a concept so that those are examples from within the framework. So part of what I'm going to lay out today is what they laid out to create some common terminology so that we can, when I talk about these alternative payment models, we're kind of talking the same language, right? So they came up with 4 categories of alternative payment models. Category 1 is simply where we are mostly today, and that's the fee-for-service model with no link to quality, no link to value. Category 2 is where you begin linking your fee-for-service payments to quality and value. So category 2A is simply think of it as an infrastructure payment. So one of the things we're going to talk about is, as we begin moving in the same direction, we've heard multiple times the importance of coordinating care within whatever system we're talking about. Most systems today don't have that infrastructure in place needed to coordinate care. And so Category 2A is simply a payment that's intended to go towards improvements that create an infrastructure that will help lead to better outcomes. So they're not necessarily tied to outcomes. It's intended to be short-term, where you help you to develop and put an infrastructure in place, but to move along this spectrum here, where you begin to link it to quality at least. So 2B is kind of a next step, if you want to think about it, where you start to incentivize people to submit their outcomes to you. So they get basically it's to get people used to start looking at data as part of what they're doing. So we ask you to look at a few data points. You provide us how you're performing to show us you're looking at it. I will pay you for reporting that data to me, simply. And then Category 2C is where we begin to actually start to pay you a little, incentivize you towards the actual outcomes that you're achieving. So what you might think of as a pay per performance. So we've now defined some quality measures that we're focused on. You've been reporting to me on them. Now we're going to set some targets. So instead of paying you for reporting to me those outcomes, I'm going to pay you for hitting a certain benchmark, a certain level of those outcomes. So that's Category 2, all right? Category 3 is where we want to begin, and 4 is where we want to begin shifting people to. So Category 3 is still built on a fee-for-service architecture, but you get into Category 2A, which are alternative payment models with shared savings, Category 2B, which are alternative payment models with what we'll call shared risk. If you're solely focused on the finance side of it, and you're not focused on tying quality to either of those, then that's what they would call a Category 2N, which you're just trying to save money, but you don't care if you're achieving good outcomes or not. Their premise, and what I would stipulate as well, is we always want to tie quality to this, so we want to avoid the 3N, and we want to be focused on 3A or 3B. And then Category 4, sorry, much like Bennett, I'm getting over an illness too, so battling some dry mouth here. Category 4 is where we can get into more actual population-based payments, or what you might think of as more prospective payment models. So, and they have different, again, subcategories. Mostly, again, if you're not tying it to quality at all, that would fall into a 4N, which is not what we're really interested in talking about here. Category 4C really is getting into big systems where they're taking full insurance risk, if you will. Think about like the Kaisers of the world. So we're really not talking about that here, but Category 4A and 4B is where we're getting into more what some people refer to as capitated type of payment system, be that for a specific population, such as your chronic pain population could fall into that category, or something more comprehensive like a total, where you're considering capitating for a total cost of care for an individual patient. So that's the framework that they developed, and that's where I want to speak to within that framework. So that's why I wanted to lay that out today. And this is what the Healthcare Payment Learning Activity Network has set as their kind of goals, if you will. So today, as you can see, Category 1, our fee for service with no link to quality and value, is where the bulk of dollars are being spent, with a little bit in Category 2, even fewer in Category 3, and a little blimp in, we have some people who are in that Category 4B, but it kind of dwindles off between 3A, 3B, and 4A. And really, we want to move to what you see on the right-hand side of your screen, that future state. Really bring people out of that fee-for-service, make that a small amount of what we're doing, and move towards these more advanced alternative payment models. Okay. I actually talked to all these already. So again, I'm going to skip through here a little bit. I will add a couple of things that I may not have mentioned. So Category 1, again, traditional fee-for-service payment. one of the things they do mention, and I'll just mention real quick, is some people think of DRGs, how hospitals might be paid as an alternative payment model, but again, it's really focused just on cost, not on quality or outcomes. So it really wouldn't fall. They don't consider that to be really an advanced alternative payment model. Just throw that out there. For in category 2, again, we kind of laid out as well. One of the other things I didn't mention that I'll just throw in here is some of that infrastructure investment may be spent on health information technology as well that might be needed to help facilitate coordination of care as well, better coordination of care as well. All right. I mentioned how both category 3 and category 4 need to be tied to quality, or what the HCP land refers to as measures of appropriate care. So this is how they define measures of appropriate care. So some of the things you want to consider as you're measuring appropriate care is avoiding wasteful tests and procedures that provide no benefit to patients, involves a high degree of care coordination to ensure efficiency in the system, encompasses everything the patient needs to achieve their personal goals, and is essential to ensure that providers are only incentivized to eliminate care that is wasteful and potentially harmful, not to reduce care just for the sake of reducing care and saving money. So it needs to bring true value. If you think of value as cost over quality, quality over cost. If you increase quality and maintain cost, you've increased value. If you decrease cost but maintain quality, you've increased value. But the sweet spot is if you increase quality and decrease cost, you significantly increase value, and that's what we're looking for here. All right, so let's get to the good stuff. Little Super Bowl theme here. Any Patriots fans? Dead silence. No Patriots fans. All right. And this will bode well for the end. So the first thing as we're thinking about designing how we want to pay for all the things we're talking about today is we need to begin with the end in mind, right? So if you're a football team, you're thinking of the first drive in the Super Bowl when you get the ball. You want to score a touchdown. That's the goal. That's the end. So you're designing plays that you think are going to make you successful to score that first touchdown. That's what we want to do here. We want to begin with the end in mind. What are the outcomes that we're trying to achieve? I'll say it one more time. I am a simple pediatrician. I am not an expert in chronic pain and substance abuse by any means. So I'm not going to throw out here what those outcomes are. I could postulate from what I've learned attending this conference, some things we may want to consider, but one thing I will say is if you can't measure it, you can't improve it. So it needs to be things that you can actually measure, right? I love this cartoon. I didn't have any accurate numbers, so I just made up this one. Studies have shown that accurate numbers aren't any more useful than the ones you make up. How many studies show that? 87. So we don't want to be making up numbers, right? We want to have good measures that we all agree upon are important to achieving the outcomes. So as we think of quality measures, one of the goals in developing and coming up with these measures is it should align incentives to drive towards a common goal. So we all need to agree upon it so we're all heading in the right direction. We may want to think about including process measures initially. So one of the things that I heard us talking about earlier is functional improvement. Well, you don't know if you're improving someone's function unless you're measuring it. So perhaps what would be considered a process measure, and one of the first steps that we might want to look at might be, and this is just an example, right, is of everyone that should have had their functionality measured, how many of them did you actually perform that functional assessment on? Not necessarily are they improving at this point, but we need to get started somewhere, so we need to incentivize you to or incentivize the process to begin looking at the things we need to look at. So that's one thing to consider. We have organizations that have developed measures and endorse measures, so we might consider utilizing some of those measures to take a look at them and see how applicable they are to this population. It's hard to develop new measures yourself that everyone's going to accept, but these are measures that experts have looked at and endorsed. Again, best determined in collaboration in a group. You need very clear baseline and benchmarks. And from my experience, I put KISS on there. We need to keep it simple to start with. And what I mean by that is we don't need to come up with 50 measures that we're trying to improve, right? We need to pick the top 2 or 3 most important things that we think reflect of the good work that we want to achieve and focus on improving those. So that would be certainly my suggestion. So begin with the end in mind. But who's going to help get you there, right? In this case, you got your big uglies, the offensive line in the football team that's going to be a big part of driving you towards that first score that you hope to achieve, or protecting your quarterback so that he can do his work. But who's going to get you there? Or think about it this way: who is as we learned from Sesame Street growing up, who are the people in your neighborhood, right? We have the concept of the medical neighborhood. Who is going to influence? Who is touching? Who's going to have an influence on the outcomes that we want to achieve? And I just came up with a partial list here. I'm sure I've heard many other pieces we might want to consider and add to this, but certainly the primary care provider. There are numerous specialists that we refer to, from addictionologists to physiatrists to psychiatrists. The hospital, both your emergency department and inpatient. You need to think about pharmacy as a partner in this endeavor as well. Your PT, chiro, yoga, acupuncture, all the other therapeutic modalities that we discussed that are evidence-based, some of which are covered by Medicaid, some of which are not today. Your other behavioral health treatment modalities that we discussed. We discussed a lot of cognitive behavioral therapy. The EMDR was brought up. What's out there today? Your peer support. What lab who's a good lab partner for you? But I also want you to think of the health plan as a partner there as well. So I threw them in there. And I'm sure I've forgotten something. I'm just laying out that we need to think about who is going to influence, who are the people in what we'll call our neighborhood that are going to influence these outcomes. Because as we develop this alternative payment model, we want to be incentivizing everyone who's going to be influencing these outcomes and driving them in the same direction. All right, what's missing? I put this in here because there may be things that you don't have in your neighborhood. Your neighborhood will look very different if you live in Dallas or San Antonio or Austin compared to Lubbock or Harlingen, or when we get into more rural East and West Texas. It's all going to look different. What's missing? What are the tools that are vital to success that we don't have today? What can we fill those gaps with? And I just threw a few things in here that we've heard about today that we would certainly consider bringing into an alternative payment model system like this. Things like Project Echo, e-consults, telemedicine, and even telehealth. And I separate telemedicine and telehealth the way the state does currently today. Telemedicine being more physician driven, where the telehealth, I would think more when we talk about doing cognitive behavioral therapy or other therapeutic type services. So, all right. The next thing we want to think about before we even think about what model we're going to turn to is who's your quarterback, right? Obviously in here, we're in Austin. Nick Foles is our quarterback in this scenario, right? Nick Foles, Austin, there we go, okay. We have some Eagles fans. Who's cheering for the Eagles tomorrow? All right. Who's not even watching the Super Bowl tomorrow? Oh my gosh, okay. Then a lot of these photos may go over most of your head, but for those of you that don't know, the one with the wings on his helmet, that's the Philadelphia Eagles. They're playing in the Super Bowl tomorrow. And that gentleman is Nick Foles, who grew up here in Austin, Texas. And if you eat anywhere in Austin, Texas, probably one of the restaurants you may have eaten at are owned by his family. So you can thank him for good food and good football. Anyway, my point with this slide is we can't, all the people in the neighborhood, we can't all be, if we're all trying to be the quarterback, if we're all trying to direct the care, it's not going to be very coordinated. It's going to end up going in very different directions. So as you look at your particular part of the state, your particular region, and we look at all the pieces that are there, we decide this is what we need to be successful. Now, who's going to be the quarterback? Who's going to be in charge of this operation? Who's going to be directing this endeavor? And we need to let them be the one directing it in the same direction. Now, they can't do it on their own, and this is where the infrastructure comes in, right? As a physician, I have a clinical perspective, but I don't have the time in my day then to begin calling all my other neighbors to make sure we're all moving in the same direction, right? That's the job in this case. I apologize again for you non-football fans, but that is the offensive coordinator. He's the one who draws up the plans for the team. He's the one who works closely with the quarterback to get them moving in the direction to score that touchdown, right? He's the one that helps coordinate what all the players are doing on the field. And that's what we need when we talk about infrastructure, all right? So we need to think about not only who is the quarterback, but what infrastructure needs to be put in place for that quarterback and all the whole team to be successful. How do we pay for that infrastructure? Okay. So we've come up with our goals. We've decided on our measures and how we're going to measure them. We've decided who needs to be involved in this. We brought them all together. We have a quarterback. One of the first things we might want to consider as part of an alternative payment model is building that infrastructure, what it is, not just what the infrastructure is, but how we pay for it. So again, just as a reminder, traditional fee-for-service payment plus payments for infrastructure investments that are used to improve care or clinical services. It's meant to be short-term. This is not a long-term solution just to give a lot of money for something and never measure the impact of it, right? Used for care coordination, could be used for non-capitated services. By non-capitated, I mean by services that are not currently covered by Medicaid, services like yoga, services like acupuncture, could be used for that. And again, something that could continue as we move to a more advanced payment model. So we have payment models where we continue to pay to support infrastructure. So it can be used in conjunction with a shared savings or shared risk model. The cost of that infrastructure payment goes towards the total cost of care in that model or the total episode of care in that model. All right. In my mind, then the next, we have our measures. We set some benchmarks for that measure. And then one option could be we do a pay per performance. So traditional fee-for-service payment plus payments for high performance on clinical quality measures. These same measures, again, the ones we chose, could be used in conjunction with a shared savings or shared risk program, and I'll explain how in just a minute, and could be used to incentivize our multiple neighbors that we've alluded to align goals. All right, then we move along the spectrum, and I'm not suggesting each community, each area of the state may have a different starting point. These are just options that I'm throwing out here as possible starting points in this process. So option 3 would be a couple of options related to category 3 payment, alternative payment models. One would be a total cost of care shared savings, shared risk model, or a chronic episode of care shared savings, shared risk model. And it could be done with a PCP or a specialist. All right, So let me explain a little bit further what I mean by that. So total cost of care, shared savings or shared risk, is cost performance compared to a target. So if you're a primary care provider and you have, in this example, a certain number of superior members, let's just say you have a panel of 100 superior members as an example, right? What we would do is look at that panel that you have today, look at the historical total cost of care for that panel over the past few years, look at the cost trends, and we would come up with a budget. We would say, this is what's been spent over the past 3 years on average. We think it's going to go up because of cost trends that we're seeing, and this is your budget for the year. These are your opportunities to perform below that budget. Usually it's through better population health management, care coordination, and where the big dollar items are keeping people out of hospitals, ERs, readmissions, looking at opportunities looking at what's being managed for pharmacy, looking at opportunities for polypharmacy, those kind of things. So there's a lot of opportunities where there is potential to reduce costs. And in this instance, if there's a savings, a percent of savings is shared back. If you put a risk into it, it's a higher risk equals more savings that are shared back. So a typical scenario under a no risk would be a 50-50 split between the provider that's doing the population health management and the plan. So I would share back 50% of you, but it's always tied to quality. So we have our target metrics, we have a benchmark, and we say, if you hit the benchmark, you get the savings kind of thing. So we make sure that with lower costs comes higher quality. We're shooting for that high value proposition. For risk, if you take on shared risk, then we may share back 75% of those savings, but if you end up being above target, then you share 25% of that, what you're above target for. So you begin to share some of the risk. So typically, for someone who's not been in a program like this before, you would start off helping them build infrastructure through an infrastructure type payment and measure how they're performing on outcomes, and then move to no risk to get them comfortable with looking at the data that's involved in doing population health management. And then after a time period of getting comfortable looking at data and managing their population, moving to a higher risk type scenario. So this is an example I threw up here this is from a couple of years ago that I brought in for one of happens to be a pediatrician that was on one of our shared savings models. And just gives you a little bit of an idea of what I'm talking about. So you can see that they ended up for the year a little over $5 per member per month under budget for a population that happened to be about 20,000 lives. And then you can see their quality score, what we call the value index score. And below that, where they performed a little above the 60th percentile compared to their peers. So it fell within a range. They needed to be above the 80th percentile to get all 50%. This fell into a range where they got 40% of the savings. So that's how a no-risk shared savings total cost of care contract might work. You can see their total cost of care is broken into different buckets in this scenario, so they can see inpatient, outpatient, professional, and pharmacy costs. I just gave you those two snapshots. Other data is given to them monthly, refreshed, including population health stratification, a predictive model of who their most high needs members are, who's emerging to be high needs to help them focus on that population health management, as well as there's some utilization data thrown in there as well. So that's the kind of data sharing that needs to be done in a model like this, though, as an example. So if you're a primary care provider and we set up a program like this with you, you would get a risk-adjusted budget like what you see for all assigned patients. It would still be, in this scenario, for a Category 3 model, a traditional fee-for-service structure to start with. So if you needed some other things like a Project Echo, if we needed infrastructure payments, any incentives we're paying to our neighbors to align everyone in place, all of that would go towards your budget as managing the total cost of care. It incentivizes you then, obviously, to coordinate with your neighbors in this scenario. And then, again, percent of savings paid tied to quality benchmarks. One other way you could do this would be to attribute to a specialist. So I'll give you an example. So for instance, take SPMI, patients with SPMI conditions, bipolar, schizophrenia, profound depression. So in a scenario like that, it's pretty easy to identify those members from data, attribute them to, say, an LMHA. So now the LMHA is the quarterback in this total cost of care scenario. They obviously need to work very closely either with having an embedded primary care provider in their practice or make a close ties with a primary care provider in the community that will also be incentivized in this scenario, but just not responsible for the total cost of care. And then perhaps at the same time, we may be incentivizing the pharmacy to do around medication adherence, which is vitally important in this population. And we may be incentivizing the inpatient facilities in this scenario around what we call an acute episode of care, where anytime someone with this condition admits to the facility, it triggers what we call an episode that lasts for 30 days beyond discharge, where they have, a budget for that episode. And if they perform for that budget, which the opportunity to do that is preventing readmissions and ER visits during that transitional time frame that's vitally important, ensuring that medication reconciliation gets done, working with the pharmacy, working with the LMHA in this scenario to make sure they're getting the follow-up care they needed. So this is a system that we're pushing everyone in the same direction, using similar measures that's driving better care to help us achieve our outcomes. So that would be from a specialist perspective. So again, a traditional fee-for-service structure, you might have infrastructure payments, which again would be counted toward the budget. If you have a primary care provider that's doing a total cost of care, the member would be removed from attribution from their assigned primary care provider in this case and attributed to the specialist. But incentives that you would still want to pay toward the PCP would be counted towards this budget, and any incentives towards neighbors like the pharmacist or the facility, like I mentioned. And again, a percent of savings tied to quality benchmarks. All right, so those are two total cost of care, Category 3 type scenarios. Another alternative payment model that falls into Category 3, 3A and 3B again, would be an episode of care that I alluded to in the previous model. Again, for something like this, with chronic pain and or substance use, you would want it to be what is called a chronic episode of care. So rather than of a short duration, typically we're talking about 180-day duration. Again, cost performance compared to a target budget would be counted towards a total cost of care shared savings, shared risk model. Percent of savings shared back, higher risk, greater upside, always tied to quality. So very similar to what we talked about. So here's a template for what I mean by an episode. So you have an episode trigger. I described to you an acute episode trigger before, which was a hospital admission, but there could be other episode triggers as well. Could be a diagnosis showing up on a claim. In some episodes, you look back a certain number of days, and then you look forward a certain number of days. So a easy example of that would be hip and knee replacement, right? The trigger is the actual procedure. You look back 45 days at the pre-op work that was done, and you look 90 days after surgery at all the follow-up care that was provided. You have that defined episode. You look at the cost of that episode across your network. You come up with a budget. If they perform below budget, you share back in a shared savings model, probably 50% contingent on them hitting certain benchmarks in quality, and more of a risk, more savings would be shared. Very straightforward. Chronic pain, maybe not so straightforward. They're probably the most commonly used episodes were developed by a company called HCI3. They were a not-for-profit company with the intent of building incentives that help improve care for specific patient populations. They were also developers. Anybody heard of the Bridges to Excellence program? They were also the creators of the Bridges to Excellence program, if you've heard of that. They were recently bought out by a company called Alterum, so they're getting more into the for-profit business now as they've expanded the work they're doing, but they still make their episodes publicly available. So they by far have developed the most episodes that are out there. So there is like an episode for substance use disorder that's pre-built, that's available to use for low back pain. So it wouldn't be too challenging to create an episode, but again, this would be a collaborative process. It's not something that's been done before. We would need to all agree what is a trigger for the episode. Are there any pre-episode costs that we need to take a look at and incorporate in, or is it purely post-episode? So something that would need to be developed. And then the fourth option, which in my mind is very much a future, is a prospective population-based payment or full risk. Again, always tied to quality. And the reason I say this is future state is because we think in this type of scenario, there's an opportunity not only to improve outcomes, but to save money, that high value proposition. And so as we build a system to optimize care for these patients, and we move towards that optimized care where we see the reduced cost and better outcomes, we're going to hit a point where we say we're achieving great outcomes with this. This is what it's costing. Now we have an idea of what it truly costs to achieve the outcomes that we're trying to hit. Now I can prospectively pay someone to do that. I can look at that cost, add some margin to it, so there's an opportunity, and you're comfortable in taking full risk in doing something like that. And the reason I say that is we do have people that want to jump to number 4, and it can work out some. It's a very risky situation, because if you don't have the infrastructure in place, if you were just paying you more money to do this, you might not be successful in this type of model to begin with. In fact, it's highly likely you won't be successful in a model like this. So that's why we need to really work towards this, but it's not the starting point, in my opinion. So, hypothetical urban scenario, again, hypothetical. Chronic episode of care triggered by diagnosis and attributed to a specialist who's the quarterback, right? So we have an addictionologist who really has a passion for this kind of work. I'm looking at this table over here to my left, the table of addictionologists over there, who really want to do this. They want to build the infrastructure. They want to coordinate the care, but they don't want to take on the total cost of care for this population. They just want to be at peace. They want to they want to work collaboratively with the primary care provider on this, and all their other neighbors. So in this scenario, my opinion, there's probably no pre-trigger services that would apply to this. So we're looking at some type of trigger. be that specific diagnosis, specific type of medication, pattern that we might see as a trigger with a first-time visit to this particular addictionologist that triggers the episode, and then we look at the costs that we build into that episode 6 months from there, and that's our chronic episode of care for this particular patient. It could include a PMPM for infrastructure if it needs to. Again, that would go towards the total episode cost, and it would include potentially incentive payments to neighbors that are part of this episode cost as well. The episode of cost would be compared to a budget with shared savings. So the budget in this scenario, so just to give you kind of an idea of what I'm talking about when I talk about an improvement model, how many people are familiar with MSSP, have heard that term, MSSP, right? The Medicaid Shared Savings Program. There was a lot written about some of the success that people saw in this program, particularly a number of ACOs in South Texas had a lot of success in savings. But it was really an improvement model, right? Because the cost of care baseline was very high compared to other places. So it was, I won't say easy, but it was not as difficult of a step in saving money in that scenario because there was already a lot of waste in the system. And so if our hypothesis is there's some waste in the system, we can, by getting in the same direction, we can shift away from more procedure-based interventions that are higher cost to more conservative-based interventions and achieve better outcomes, like we've talked about, by bringing in other tools, using some of our behavioral health tools, then we have some opportunity to lower the cost there. So this is our improvement model, which is going to lead us towards more of a long-term, the category 4. So that's a hypothetical place to start in an urban setting, potentially. Again, hypothetical. Could vary, the needs of Dallas could vary from San Antonio, from Houston. Rural, though, where we may not have as many resources. So again, to make this significant to a rural provider, we probably would need to do a total cost of care model for their whole population, where the management of the chronic pain patient would be a piece of what they're doing for population health management for their whole population. And the reason I say that is you need to have enough patients involved in an alternative payment model like this to make it meaningful, right? So if you have 2 or 3 chronic pain patients as part of a panel of 100, if I just try to do an alternative payment model for those 2 or 3 patients, it's not gonna, because the denominator is so low, it could really swing the budget greatly just trying to do it on 2 to 3, and certainly quality outcomes. You can imagine with 2 people, you go wrong with one of them, and you've already lost the opportunity to hit your benchmark. So that's the reason I would suggest in a rural setting, we would definitely want to look at a total cost of care program for our whole population. Again, could include PMPM for any needed infrastructure, could include, if need be, the Project Echo, telemedicine, telehealth, whatever additional support that we deem necessary in that area, any incentives to those neighbors, and again, actual cost compared to budget with shared savings was contingent on quality. In this case, it might go the quality measures because we're looking at the total population. We might focus one of those measures on what we've talked about previously for chronic pain, but we need to also have some measures pertinent to the population as a whole. All right. So I'm not ending with the magical number. I was afraid everyone was expecting something. But, and again, I apologize to you non-football fans, but we have a common enemy of chronic pain and substance use. And I think we all want to achieve, we all have the same goal in mind, right? We want better health outcomes for these people. and we see the opportunity there. So we can all get on board and go together. We can all agree we hate the Patriots, right? So anyway, I will open it up to questions now. I've talked a lot. So any questions? You're not allowed to ask questions. You're too smart for me. Go ahead.
One of the things that I found in seeing a lot of different places trying to implement programs, and it's not a knowledge-based problem, it's actually a process engineering problem, and getting them to help to actually process engineer the workflows required to do screening and intervention, referral to treatment, and make sure that people are able to do that. That can be pretty expensive, and I'm wondering if that's part of the calculation of the baseline budget, or if that's some outside infrastructure build capability.
That's a good question. So, Ben and I were just having he's actually already process mapped out the whole thing. So, I think he's part engineer. So, but no, I think you're right. As we've begun some work around other trying to move providers to do more population health management, it can be very challenging. To move from a fee-for-service environment to focusing on it, because it really changes the way you do work within your practice, right? And so I know there are a couple of options, I think, for people that want to do some practice transformation and learn to build those kind of workflows within their practice or within the community at large. We've brought in some transformational coaching to some of our larger providers to help facilitate that. I think we heard from a number of our echo providers that they actually have some echoes around those transformation activities. I think if I had, my dream, we would get some key players from the community, go into the community, collaborate on designing what you're talking about, the process flows within the community, but then it's creating the infrastructure to follow that process diagram. I'm not suggesting it's simple, but I think it needs to be a collaborative process that everyone agrees upon, but I'm not including it as part of the cost, if that's something separate that we would help participate in. Yes, sir. Sure. As we're beginning to learn more about episodes of care, so episodes of care from a health plan perspective is something we're working on rolling out some this year. Some are easier to design than others, but in general, think of it in this way: you have episodes that are geared towards acute events, episodes towards procedure, improving outcomes related to certain procedures. I mentioned the knee and hip replacement, and then there's episodes geared towards more chronic events, and then there's kind of these episodes that just fall into not one of those three categories. So, you wouldn't consider a maternity episode to really be a chronic condition, right? So some people might. I'm not going to suggest that it is here in a public forum. And so that would fall into the other category. So, for instance, one of the episodes that's been developed, I think you're alluding to, there's a low back pain condition. So you could focus on people with low back pain. That's one that certainly has been well developed. And then there's one that's been developed on substance use disorder. There's ones that are developed on other behavioral health conditions that may be comorbid. I know we're going to hear about dealing with depression and anxiety. So there are episodes around mood disorders, post-traumatic stress, There's a developed episode. So you could focus on, to your point, a particular subset of this chronic pain population. Yes, sir.
Thinking about your models for total cost of care and comparing that with PPP, where some year one you might win, but year two you might lose because you won in year one, and readjust those budgets. What certainty is there for providers that they're going to continue to be incentivized to provide higher value care?
Right, that's a good point. So I think that's where you really have to be kind of cognizant of moving people along a specific pathway, right? So we're going to start with what you've just described and what I refer to as an improvement model. We think there's an opportunity to get better. There's going to come a point where I've gotten better, I'm achieving outcomes, but I think from a cost standpoint, I've done most of what I can. But I think I can at least maintain. And so a couple of options there. One is I'm willing to share some risk with you now. So my savings may not be as much in totality, but now because I'm taking on some risk, I get more of that saving, so I can at least earn what I did previously through taking on some risk. In that scenario, typically, I will tell you what we do as a plan. Once someone is willing to take on some shared risk, we also add a little cushion to the budget as well. So maybe add 2% on top of the budget as a cushion to also make them more comfortable with taking on some risk. But then you get to the point where then we're going to do a prospective payment, right? That's when we begin. We know we need to make that move, and we say, you're going to take on full risk. We're going to give you this payment, which we know has this much margin built in, but is way cheaper than what we're doing today because you're doing such a great, awesome job. And so you have to work together and make that decision together when we move that next step down the pathway to ensure that you're not going to have this expectation, I made this much money this year and now I've done all I can, I made nothing this year, right? I think that varies from practice to practice. Some of them, the ones we've worked with to date, have really embraced this and moved to a population health management approach. Others have tried to approach it from, we're just going to keep doing what we've been doing and see what happens. And they have not been quite as successful. So for most, we've been working a couple of years with them, and we have, so we started off working with about what I'll call 25 large networks. We do either large group practices or IPAs, and we probably have about 5 we've targeted with discussions to move on to taking risk after doing that for 2 years. Yes, sir. Sure. So we have a whole team that's part of their focus is on improving provider performance or replicating performance for high-performing providers. And so a subset part of that is on advancing alternative payment models within our system. So we do have a team of people that, for those that are participating, we have what you saw as a screenshot of an online dashboard that's refreshed on a monthly basis that has drill down capabilities to a provider level within a group, to a member, a patient level, to give you a whole snapshot of the patient. So it's a nice tool, but we have folks that go out and educate you on the tool, meet with you regularly to make sure you're using the tool, understand how to use the tool, or identifying opportunities within your data of what you might want to focus on. That's some of the transformation activity we've talked about as well. So that's a snapshot of some of the work we're doing. I saw one other, last one I'm told. Sorry. Yes, sir.
Thank you for the great talk, by the way. Can you comment on what types of measures, coming from a payer perspective, you're thinking of in terms of measuring outcomes for chronic pain
So, yes, well, you're very generous about the talk, but so I will say our focus on what we've rolled out to date has been very patient-centered. So you saw the value index score, which is basically was developed by, so we partnered with 3M in this endeavor, just so you know, with our dashboard. They're the ones who manage the dashboard for us. The value index score is something that is proprietary to them, but basically when you look at the measures that go into it, it's really evaluating on how well you're coordinating care and keeping the patient at the center. It does have some wellness stuff in it. I will tell you, the state for Medicaid holds plans accountable for achieving certain measures as well. And so this year, as that program has kicked in, we've added an additional, what I call a quality kicker. So the percent we save is contingent on how well you perform on that value index score, but you can earn some additional money on top of that by focusing on these few HEDIS measures to improve as well. As far as what we might focus on from a chronic pain, I think I alluded to measuring functional ability certainly might be one of them. There are some measures that are coming out around opioid utilization as well. So those would be a couple, if I had to pick some pertinent ones off the top of my head that we might want to take a look at as opportunities where we are. Looking back where we might be baseline and an opportunity to improve. That's just off the top of my head. And again, I'm not an expert, so would value certainly the feedback from people that are. But thank you very much. Appreciate it.